Welcome back to the Industrialized, Interoperable, and Insight-Driven Federal Health Panel, sponsored by Accenture here on Federal News Radio 1500 AM and federalnewsradio.com. Our guests today are Jim Traficant, the Managing Director for Accenture Federal Services and the President of ASM Research, Dr. Kaveh Safave, the Global Managing Director for Healthcare at Accenture, Stanley Huff, the Chief Medical Informatics Officer of Intermountain Healthcare, and Dr. Bart Harmon, the President of Clinical Informatics Experts. And Dr. Harmon, I wanted to ask you one more question on interoperability, and that is DoD is really not just DoD, but it has deep roots into the commercial healthcare sector by virtue of the military health system. And so there's already a lot of interoperability happening there. Tell us your thoughts there.
Sure. In the broader context, the system that delivers healthcare to military personnel doesn't really know any absolute bounds. For example, people who have severe amputation-type injuries might still be on active duty, but because they're recovering for a year and a half, they may go home and receive their routine care from the VA and their urgent care from a small community hospital near their home. Then they're back to Walter Reed or wherever it is for their continuing health care on active duty. When they retire from the military, the VA is their primary, but they may come back to DoD for tuning of high-tech prosthetics, for example. When people are deployed, the military health system needs to interoperate with other NATO allies, for example. The U.S. may take care of Brits. The Brits may take care of our people. And when we hand the people back, we should be handing electrons back so we can have continuity of care and information. So the true system that delivers military health is very unbounded compared to the quote, military health system which is operated by the military.
So the DoD really operates kind of at the hub of a really big wheel with lots of spokes going into different pieces. And so that gets to the mission. And Jim, I know you've thought about the issue of the mission and the national security implications of better healthcare informatics, better information sharing, better interoperability. And we wanted to talk more about that. So why don't you kick off that part of the discussion, and what are the national security implications?
Yeah, I think they come in a couple different ways. One is when you think about the amount of money that we spend on healthcare as a country, it's the largest percentage of GDP of any of the discretionary spend, and we're not getting nearly the return on that investment that we would expect. So, if you flash back to the Cold War and you looked at the military strength of the United States as we confronted the then Soviet Union, we had not only military might, but economic strength to back it up. And in that instance, we raised the stakes with a Republican administration and a Democratic Congress with something called Star Wars. And it wasn't that we were going to have a shield overnight. It was that we were forcing the Soviet Union to raise the stakes economically, and they were unable to do so. So the strength that we demonstrated militarily was also backed up economically. Today, the tables are turned. We have $16 trillion in debt, and there are other countries and those that are threats to us that are economically stronger than we are. And the greatest drag in our economy is health. So I think in terms of national security, that certainly is one. Secondly, I think about force readiness of the military. Primary mission of the Department of Defense is to be able to deploy and support wherever they're needed, whenever they're needed, globally. And that part of the mission has a clear alignment between healthcare and force readiness and national security. So I think both dimensions are critical.
And what do you see around the world?
The same problems exist. Healthcare as a public expense competes with other discretionary expenses. The more we spend on healthcare, the less is available for other public purposes, including defense, but also education, housing, infrastructure, everything you can think of. Within an organization like the military, when health is actually a big part of the cost structure, you have the double-edged sword of at the macro level, it reduces the amount of money available for military, and then within the military, it consumes. It's the exact same story you see in all countries. Interestingly enough, there really isn't a country in the world that doesn't think about healthcare affordability at some level. Even emerging markets where they worry about access, they still worry about affordability because it consumes a significant part of gross domestic product.
I think it was former Secretary Bob Gates who said that the healthcare costs, his words, eating us alive in DoD, and here we are, 6, 7 years later, and I guess they still are. And what about in the private sector as you view it, Stan, at Intermountain Healthcare? Is it worrying people to death? Is that part of the health problem or national security implication?
Yeah, it's really the same situation. As we contract, as we move to, step back a little bit. One of the things that Intermountain does is actually provides health insurance for groups. So we have a health insurance division that insures 600,000 lives in Utah. Our primary customers there are businesses. So we're providing, and the businesses come and say, how can we be competitive nationally and especially internationally if 25% of our costs are healthcare costs? And so it's a tremendous problem, in the private sector as well. I mean, we're very focused. Our chief financial officer has set a goal that we would be cost of living plus 1%, which is dramatically different. That means, to us, that we've got to reduce our costs and our expenses by $400 million to meet that goal. But it's constantly on our mind how we can be more efficient and how we can take cost out of that, because it injures us in terms of our competitive, being effective and competitive in the world, to not contain those costs and have them be reasonable compared to other expenses.
Yeah, as Jim said, ultimately it's the strength of the economy that pays for everything else, and I guess the strength of the economy to some extent depends on the strength and health of individual citizens. So, Bart, do you see that as an issue that's affecting a lot of large and small outfits?
Absolutely. Yeah, I think it's a universal effect across the U.S. and probably internationally too. Basically a weakening of the enterprises financially because of the cost of healthcare. And obviously some of the answers are to invest in the things that are higher leverage. It's much cheaper to immunize a child than to take care of a child in an intensive care unit. It's cheaper to prevent disease than it is to treat advanced illness. And so, shifting where the focus is to things that are higher leverage, and shifting the payment policies to incentivize the things that are higher leverage. People respond to the system around them, and many of the incentives are financial reimbursement payment incentives that the incentive structure needs to be shifted a bit so that you can move the whole system in a different direction. The healthcare system is like a bug caught in a spider web. You have to loosen up multiple threads on one side and tighten up threads on the other side to get movement. Otherwise, the forces tend to pull the system right back to where it started. And that's part of what we're dealing with. Tort reform is another one that might be a touchy subject, but people practice defensively too. It's a whole bunch of different influences that all come together to shape the way healthcare is delivered and the cost structure of healthcare in the United States.
And yet at the center of all these problems, Dr. Savavi, it seems like informatics, information, data can provide a mitigating factor.
Sure. I think the ability to know and then to do a better job in terms of everything from identifying, for example, who might get sick and intervening, helping a hospital know which patients to treat in what order, or to make sure that they're following protocols. These are all really simple things, but interoperability can even go beyond that. It really can allow, for example, physicians who are in different locations to take care of a patient when the right thing for that patient is to see certain specialties or certain physicians that may not be located in the same institution. And really, from an access and effectiveness perspective, the ability to have a system that gives patients the right or the ability to have the best possible clinical setting is also contingent on an interoperable system. So it cuts in many ways beyond the data.
And Jim, there's kind of an irony at VA. The costs are rising, the budgets for it keep rising, yet in point of fact, the number of veterans is actually dropping. So you've got curves going in opposite directions and really no end in sight, especially as the Afghanistan and Iraq generation of veterans ages, and they have, as you say, they've survived things that earlier veterans might not have survived, which mitigates in favor of more continuous care as they get older. And so, turning away from the DoD for a minute, looking at VA, what do you see as the ways they can start to look at this strategically, say for 20, 30, 40 years down the line?
I think there's trends both in federal as well as the private sector that say With the digitization of health, and the DoD and VA have been pioneers in that area, capturing the data is one thing. This interoperability framework, or connecting healthcare so that we could now communicate and have a richer data set to deliver care. In the military, we'd call it situational awareness. Right before you engage, you want all the information you can gather on the particular activity, and then you go and make decisions based on that richer data set. I think the opportunity comes with, now that we have the data, can we make it insight-driven? Can we begin to make sense out of it that will help us deliver more streamlined care, that we can get better outcomes as a result of the information, and we start unlocking the data silos that exist in healthcare with this connected framework and allow us to get to the analytics. Martin Harris at Cleveland Clinic just said in this past week, we will not get to big data in healthcare until we get the connected framework resolved in health, and then we can make sense out of the information and transform it.
And Bart, what are some of the infrastructure issues to support all of this? Do you find that that's sufficient the way it exists now? We've got networks and cloud computing centers and all of this, or does that have to be looked at also to support all of this data-driven medical thinking and decision-making?
It definitely has to be considered, especially if you consider the infrastructure to be a little bit higher in the infrastructure stack than it traditionally has been. I think we probably have the communication bandwidth and the ability to move electrons that we would need. But to make sure that we have appropriate security and can abide by the different security protocols of organizations that are as different as a small community hospital, a large health enterprise, a VA, and a defense organization has security requirements that can be a little different than some of the others. And to figure out how to appropriately and effectively protect information and yet move it when needed is challenging. And I would consider the security protocols and profiles to be part of the infrastructure. And access controls and authorization of people to access records, in some ways, are part of the infrastructure. So some of the more advanced or higher level aspects of infrastructure, I think we still have some really fundamental challenges where the ability to buy enough bandwidth to move electrons, I think probably we can do that. It's a lot less expensive than dealing with the more complicated aspects.
So cybersecurity is a factor in all of this to protect. That is what we're trying to build to protect the people. Absolutely. And Stan, you said there's 1,000 people working in IT where you are. What do they do?
They do a lot of things. A set of them are worried about billing. That's a whole subject unto itself. I think, unfortunately, I'll say a few provocative things maybe. One is our systems today are probably more worried about billing accuracy than they are patient care, unfortunately. What we document is not what we need to take care of the patient. We document what we need so that we can get accurately billed for the work. So there are a bunch of them who worry about billing. There are a bunch of them that worry about how to create measure information and send it to the government so they can make incentives. There are some of them creating interfaces. There's some of them that are working with clinicians to develop, clinical decision support applications and those kind of things. But I think one of the things that come to mind as I hear the discussion here, there's another aspect to interoperability that I think we don't want to overlook, and that is what I would call the ability to share knowledge in an executable form. So they're sharing data, and that helps prevent people reordering tests and that sort of thing. But the real benefit from these information systems, I think, goes much beyond that. Coming back to how do we get to reducing medical costs, it doesn't actually. I don't think we're going to get huge reduction in costs by sharing data. The only way you can get to the kind of reductions that we need to get to is to not do things that don't need to be done. And we have to, there might be political things we need to do to enable that. But the other thing is we need to be able to share executable knowledge that says, what's the best way to take care of someone with sepsis? What's the best way to take care of somebody with community-acquired pneumonia? And have that be implementable and shared in the system. And so we're sharing executable rules. That's a different kind of interoperability than sort of the data interoperability we've been talking about. And I actually think the payoff from knowledge sharing and being able to share that kind of clinical knowledge in an executable form will actually pay bigger dividends than the actual data sharing. I don't want to diminish data sharing. That's absolutely important. But I think actually the greater benefit to the country will be in knowledge sharing.
So it sounds like worldwide, maybe it's safe to say, and I'm asking this of Dr. Safavi, the interoperability is maybe a symptom of the greater issue, which is knowledge management. And you can't have it without interoperability, but interoperability is not the end, it's the means.
It's a means to an end. I think that what Stan said is really interesting and important, because we often think about interoperability as facilitating the movement of my information to other care providers who care for me. What Stan's really talking about is when you make this technology interoperable, then I can develop a knowledge of how to treat you that someone, not you, can benefit from. I don't need that person's data, but if we had an interoperable system, I could deliver my app to you, to another doctor caring for you, who could give you the same benefit. And that actually will probably have a greater economic impact over time than the fact that my data could go anywhere in the world that I go, because ultimately I only represent a small percentage of the total.
And it might even give better operational results in a case like the recent Ebola situation, where maybe if the government and the providers had more of that knowledge sharing, it wouldn't have looked so disjointed and kind of scary at the beginning of it.
Yeah, I mean, the information can be shared the old-fashioned way, but I think the idea
Television.
but I think the idea of putting rules that can essentially work your way through the decision-making process improves the number of people who can get access to it and the likelihood that it will be followed. I think that's really the objective.
All right. On that note, we're going to take a short break. Our guests today are Dr. Kaveh Safavi, the Global Managing Director of the Health Industry for Accenture, Stan Huff, the Chief Medical Informatics Officer of Intermountain Healthcare, Dr. Bart Harmon, the President of Clinical Informatics Experts, and Jim Traficant, the Managing Director for Accenture Federal Services and the President of ASM Research. I'm your moderator, Tom Temin. This is Industrialized, Interoperable, and Insight-Driven Federal Health Panel, sponsored by Accenture, here on Federal News Radio 1500 AM and federalnewsradio.com.